Hi, I'm Dr. Rudy Cashman, neurosurgeon in Fort Wayne, Indiana for 42 years, but I'm only 39 years old. No, all kidding aside, you can also call me Dr. Wellness, Dr. Second Opinion. I've taken a great interest on getting patients well without invasive procedures, dangerous medications, and operations. Yet, I do 250 operations a year. I totally believe in Western medicine. Today's subject, to me, is extremely important because I see patients with pain every day. I see patients with pain problems every day who have been mistreated. And I think this is a big problem throughout the United States, not just here in Fort Wayne, Indiana. And I personally think pain needs a new definition. And I'll explain to you what I mean by that. I also think that pain clinics are a national scandal across the country. Certainly there are a few good ones, but you read the stories everywhere on the internet and in the newspaper. So in about 6 weeks I'll have another book coming out, and this one will be called Pain, a New Definition, and Pain Clinics, a National Scandal. And we're going to go through this subject in some detail to explain to you where I'm coming from. What is pain? People, I speak to many providers today, nurses, patients especially, they have no idea. What's a good definition of pain? So let's go through this a little bit. What is pain? It's a sensation, it's an emotion, and it's a perception. So it is different things to different people. So what is it divided into? We have acute pain. You break your leg, an impulse goes up the spinal cord to your brain. It tells you where the problem is. We put a cast on it. We may give you a narcotic for a short period of time or some other pain medication, and there's an end point. There's an end point, and we stop it. The odds of getting addicted is quite small in acute pain, but that's only 10% of the pain problems. Yes, only 10%. 90% of the pain problems are what's called chronic pain. That's pain more than 6 months. So that is millions of people in this country have chronic pain problems. And chronic pain is sort of divided into neuropathic. That means nerve damage. Shark bites off your leg, the femoral nerve is exposed, and that's nerve pain. Pinched nerve, like my last patient today had a big ruptured disc, terrible pain down her leg, and that's neuropathic pain. Trigeminal neuralgia, severe arthritis. So there's real pathology, well demonstrated, but that's only 10% of the pain problems. When you talk to some people writing pain books, they think it's 90%. No, it's about 10%, and that's well confirmed. Then we have nociceptive pain. That's bursitis, tendonitis, tennis elbow, which I'm quite experienced with, many years of playing tennis. That's nociceptive pain. What do you treat it with? Oh, with some ice, with some heat, with some exercise, maybe an injection, maybe a short-term course of a steroid or even a narcotic for a week or two, but you don't treat it long-term with a narcotic medication. So we're up to about 30%. What about the other 70%? What do we call them? I read 3 pain books recently. They don't even bring them up. What do they call it? Idiopathic? Who wants to be an idiot? Or pathetic? We have to have a name for these people. These are the ones that go to the emergency room, and the first thing the nurse says, and what's the level of your pain? And the patient says, it's a 9, and the patient gets some Dilaudid ready. She never asks why you hurt, and that's a big mistake. That's a big mistake because that patient may be in that 70%. Now, I made up a name for them. I'd have checked it with a psychiatrist. He thought it's not a bad name. I call it metabolic pain. It doesn't have any particular meaning, except it means it's the patients where we do not know why they hurt. And these are the patients that I believe in this nation, in this city, we're over-treating with narcotics and turning a significant amount of these people into addicts. I see them every day. I saw one today. And the patients are totally aware of it, that they've been addicted by the provider, because they're speaking about pain. They don't say I'm addicted. They say I hurt. And I have to explain to them why I don't think narcotics are appropriate. So chronic pain really represents the bumps and bruises of your life. Listen to that again. The bumps and bruises of your life. So what else are the bumps and bruises of your life? They can be divorce. It can be job loss. It can be family relations, anxiety, depression, anger, fear. These are the bumps of your life. And we don't come in telling the doctor, I'm in fear. We go see the doctor many times with a chronic pain problem. The brain misrepresents you, and these are the patients that providers will go to work on with injections, with narcotic medication. And so chronic pain can be due to anxiety, fear, hopelessness, depression, a feeling of scarcity. So pain is not a diagnosis. It's a symptom. There are even books written that it should be a diagnosis. If we make pain a diagnosis, we will addict the whole country. We now are, frankly, a pain nation. To other countries where they don't see anywhere near these kind of pain problems. We are developing a pain nation largely because of this fifth vital sign created by the Joint Commission of Hospitals, where you go to the emergency room and they don't say, where do you hurt or what is your problem? They say, what's the level of your pain? I think it's a major error. There's some emergency rooms in this area. In a book I wrote called The Fraud of Chronic Pain, it's on Amazon, where I had a nurse write out for me a number of chapters and said in some shifts at this certain hospital, every patient that came in, they gave them a narcotic because the sign on the wall says, what's the level of your pain? 0 to 10. Instead of, why are you here? What's the problem? That's, like I mentioned, it's a major error. So what we are creating really with all these narcotic medications we're handing out, we're developing legal addicts. These people don't have to hit the street. They get the narcotic from the pain center, from their provider. He's the one that hands out the Percocet, the OxyContin, the morphine. They're not breaking the law. They're not breaking the law. But what are we doing with them? Creating addicts. OxyContin, for example, can make an addict out of you 1 week. 5 days. It's in the literature. So you have to be very careful before you accept a narcotic medication. You had a heart attack. You get a broken leg. A ruptured bowel. For Pete's sake, accept a narcotic. But for routine problems, don't accept a narcotic because you could become addicted very quickly. And once you're addicted, you know what the odds are of getting rid of your addiction? 10% maybe. That's it. Your life is ruined. And so be very careful before accepting a narcotic. And this is a scandal throughout the country. All you have to do is pick up the newspaper and read about it. The Buddhists talk about acute pain as arrow 1 pain. They call it arrow 1 pain. It's the beginning and the end, and it's over. They consider arrow 2 pain is where you decorate the pain with the past and with the future. Remember what I said about chronic pain? It's the bumps and bruises of your life. It's decorated with emotions. And a lot of people cannot handle these pain problems, and that's why they go to the emergency room. They go to the pain center because they don't accept or are mindful of the pain, which many times isn't really quite as bad as they seem to think it is, because they decorate it. They decorate it. And with addictions, for example, food addictions. Food's a drug. Food's a drug. It's like cocaine. With cigarettes, with alcohol, with drugs, with anger. And then eventually they may drown in the pain, overwhelmed. They're exhausted. They're screaming for relief because what do narcotics do? They give you dopamine and serotonin. They're feel-good drugs. But how else do we get dopamine and serotonin? Deep breathing techniques will bring them out, like Lamaze brings them out, relieves pain. Music brings them out. Music brings them out. When you think of one of the Gibbs brothers dying yesterday. That beautiful music for dancing. Can you imagine the amount of dopamine and serotonin they produced in their wonderful music over the years? I remember it very well. Sex, it's quick dopamine and serotonin. Narcotics is a huge rise very quickly, very high, and that's why people want to re-achieve this overwhelming craving, and that's why they seek these narcotics. They build receptor sites in the brain that need to be satisfied to this addiction. So when giving narcotic medications to patients, or even other anxiety drugs, for example, Xanax, Librium, Valium, they can do the same thing. We must have an endpoint. Of course, if we're dealing with cancer, for example, that would be a neuropathic pain. Give all the narcotics you want. It's not a problem. These people do not have a problem with addiction. I mean, chronic pain is like a soap opera, okay? What are a lot of these patients, if you take some history, what do they have? Divorce, rape, spouse abuse, incest, depression, child abuse, grief, alcoholism, suicides, bankruptcy, drug addiction, unemployment, dead-end jobs, impoverished family, too many children. This is a lot in the history of the chronic pain patient. So to walk in there and say, what is the level of your pain as the opening statement, it is absolutely ridiculous. The best thing you could do, unless they're dying, hand them a yellow pad and a pencil and have them write out the history. Or sit there and take the history, which is the best of all. Like I did today, I had a patient today, he weighed 380 pounds. He'd been to 3 different pain clinics from Indianapolis to Peru to Fort Wayne, and they had all addicted him to drugs. He had about 6 or 7 injections. I read his x-rays. I couldn't believe it. Normally I can look at a person and judge what the MRI will look like by their size and their age and how much work they have done. I was wrong in this one. I could guess correctly 90% of the time what it is. He had normal x-rays. They were the x-ray of a 20-year-old person. He was incredulous when I told him his x-rays were normal for his age. So what does this backache do to? Probably weak muscles is one thing, but I'll tell you what else. Drug addiction. Drug addiction. He was on OxyContin, 20 milligrams 4 times a day, and Lortab for a break through pain, none of which was necessary. None of that was necessary as he had purely a muscular condition, and I had to spend a lot of time explaining to him, and I think I made friends with him. I'm going to see him back once a month, and I put him on a 3-month schedule of getting off the narcotic medication, and also, since I've written 5 books on proper eating, guess what? I taught him also nutrient-dense eating, and we ended up friends. I took a picture of him and me together because I told him once a month we're going to take a picture because I want to see his body contract, get rid of his type 2 diabetes, improve his pain problem. But that's how benign. So what did he have? He had a metabolic pain problem. Okay, it wasn't due to his degenerative disc disease. René Descartes, 1635, wrote a very famous book. Obviously, when the Renaissance began, he thought pain was like ringing a bell, like a rope went up the body and you rang a bell in the brain and the pain was turned on. Big mistake. He didn't attach the brain to the body. He forgot. We're not just ringing a bell up there that says we're pain. He forgot to decorate it with the emotion, the anxiety, the fear, the stress, the anger. That's metabolic pain. It's the bumps and bruises of our life. That's what chronic pain really is. So if you take narcotic medication, some people get addicted in a week, some in a month, and some it takes a long time. But first, it gets to be a habit, and then you become tolerant of it. And then you start building receptor sites in your brain that need to be satisfied. So you always need more. You know, you start with Percodan, and then maybe Lortabs, and then eventually you end up with fentanyl patches. and morphine, and eventually on methadone. And methadone is dangerous, very dangerous. It can change your heart rhythm, and it has a long half-life. A significant number of people die from these medications. There have been 70 deaths last year from physician prescriptions in these surrounding counties. Across the country, 15,000. 15,000 across the country, people that were overdosed from the narcotics in combination with their tranquilizers and were found dead at home. And that's right out of the newspapers. There was a letter to the New York Times over this weekend written by the head of the drug and addiction at the federal level, the CEO in charge of that. And he said that in this country, we spend $500 billion a year for addictions. That's cigarettes, alcohol, and narcotics. $500 billion, $500 billion. 600,000 people die from their addictions. 600,000 people die from their addiction. Just think of that. I mean, you talk about a war. This is a real war. And what about the disabled? Some overdose, their brains shrink. We always knew that alcohol consumption, alcoholics, their brains shrink because I've looked at MRIs all the time. But I was reading a man who does PET scans and SPECT scans, a radiologist, and he is saying that long-time drug abusers, their brain shrinks just like the alcoholic. I did not know that. Just like the alcoholic. And he showed films to prove the point. And these people were only on narcotics, not alcohol. So these narcotics are also toxic to the brain. Let's review the history of pain treatment a little bit here. And this has been for years, 2,000 years at least. Opium has been used as a pain reliever in all kinds of concoctions, okay? Then eventually in the 1800s they extracted morphine from it, and morphine was used in different concoctions. In the First World War, around that time, not just the soldiers, but also the people, this country, we had 300,000 people addicted. That's where the word habituation and addiction was termed, okay? The government reacted by passing the Harrison Act. And it was mainly statistical and a taxing system. But in 1919, the Supreme Court put out a ruling that if you gave narcotics to a known addict, it was against federal law. Guess what happened? 25,000 doctors had to go to court. 25,000 doctors. So that put a little teeth into it, and I think pain was probably undertreated for a few decades. So Sloan Kettering in New York, a cancer hospital, thought cancer patients were being undertreated. Perfectly understandable, and they promoted the use of morphine drips, things like that. So the cancer patients in their terminal weeks or months or days would have a very smooth pain relief. And M.S. Contin came out about 1984, and the Purdue company, this has nothing to do with the university, Purdue Frederick Company, which founded in New York City, it was bought by Arthur, Richard, and Mesmore Sackley, three guys from New York. Very interesting. And they bought a company, the Rapp Company in England, who in turn bought another company in Scotland, and they had the technology for time-release narcotic medication. And MS Contin was the big one. It would last 12 hours. It was great relief for cancer patients. It was just great. But then a couple of doctors working at Sloan Kettering decided that it works so good for cancer patients that perhaps these narcotic medications could be used for non-malignant pain, non-cancer pain, okay? And they reviewed about 3 papers that were not good studies, but one was in pain, another one was in New England Journal of Medicine, and and a Dr. Portnoy and a Karen Foley, who were doctors at Sloan Kettering, started promoting the use of these medications for non-malignant pain. They left Sloan Kettering and moved over to Mount Sinai Hospital in New York, and Einstein Hospital. They work through them too, and start publishing papers on this, that it's okay to use narcotic medications for non-malignant pain. And in 1986 or so, the pain clinic was born. And it was based on that, called Chronic Use of Opioid. Those are those drugs that are made from morphine, opioids, analgesics. Enormous impact. Just had enormous impact. And the country responded to it, and it catapulted Dr. Portnoy and Dr. Foley into the public light. And Dr. Portnoy, at age 31, was a great public speaker, and he frankly convinced the whole country it's safe to use these medications for non-malignant pain. And the Purdue Frederick Company and the Sackleys picked up on that, and they financed Dr. Foley and Dr. Portnoy so they could lecture all over the country. They give them money to do this. They would gather 1,000 doctors at a time, send them to a nice vacation place. They give them a lecture, an informational, you might say, and promoting MS Contin, for example. And then a new drug was coming along also, OxyContin, made from hydrocodone. Hydrocodone, say in Percocet, is 5 milligrams of hydrocodone, okay? But OxyContin is 100 milligrams of hydrocodone. Much stronger, a highly addictive drug, but they didn't advertise it being addictive. Matter of fact, Portnoy and Foley would say your odds of becoming addicted to a narcotic like morphine was 1%, based on no studies, based on no scientific studies. And matter of fact, they said in the World War I, what they said about morphine was incorrect. They implied it was incorrect. But in other papers that Dr. Portnoy would publish in more quiet journals, for example, he was not as optimistic about it. He was covering his tracks. So he became a great speaker. And the conclusion of Portnoy and Foley was, we conclude that opioid maintenance therapy can be safe. Dead wrong. 15,000 people died this year from physician narcotic prescriptions. How many disabled? Probably a million. Probably a million. I see these people all the time. And so they promoted it a big time. And remember, I said the three papers they were quoting out of was, one was in Headache, one in New England Journal of Medicine, the other one in Pain Magazine. In 1972 was the first international pain conference. It was held in the state of Washington. And that's sort of started the pain movement. They formed a pain society where people made a few years and study pain. And they promoted narcotic use for non-malignant pain. Remember I said to use narcotics for cancer, for Pete's sake, use all you want. Keep the patient comfortable. For some neuropathic pain, you have to use it too. But there's a pharmaceutical law that says narcotics only work in 30% of the patients 30% of the time. It's throughout the pharmacological literature. Most people are not aware of that. Arthur and Richard and Mortimer Sackley promoted their Purdue Company products all over the world. They also had the rights to distribute Librium and Valium. Can you think of that? Look at the sales in that. And Betadine. Look at the sales in that. They were a specialized company, but no really good scientific studies in the population were ever done on OxyContin. Now, for example, they were saying that OxyContin probably would not be abused as much because it had a 12-hour time release. Dead wrong again. The street people figured out pretty quickly that you could chew it, break it up, and get an overwhelming high very quickly. So it became an abusive drug very quickly. You could fill an OxyContin prescription, and most of the time insurance would even pay for it. 40 cents a pill, get 100 pills. You know what we can sell it for in the street? $4,000 to $8,000. Guess what the people are doing? It happens all the time. Patients of mine sit in a pain clinic. People are talking about it. The people are talking about it. And so this was the birth of the pain center. So I think and also the Sackley family were the first one to develop a system of tracking physician prescriptions. In other words, they would find out who the doctors were writing all this stuff, and they go in there, send a salesman in there. And it doesn't make you wonder. I probably haven't seen a salesperson, and I work full time, promoting a drug maybe 5 years. Matter of fact, of all my years of 42-year practice, I can only frankly remember what they look like, a salesperson. The only one I can ever remember was the OxyContin sales lady I saw maybe 10 years ago. She called on me 3 times. I'm so proud of myself. I didn't know as much then as I know now, that I didn't fall for her sales pitch. It's a very dangerous drug, but a very dangerous drug. So the Sackleys also formed the birth for the informational for doctors. They're the first one that paid for people to call in doctors. That wasn't done before. They paid for the informational conference for doctors. I remember going to one of those, actually, till I woke up and realized what they were. And they still hold those today, although I think the government is just a little bit controlled, so it's a little tougher. And what these drugs do is they suppress your own morphine. You have dopamine in your body that, like, if you do some deep breathing, you can cause dopamine to be secreted, or you run or do some exercise, or music will secrete dopamine, and you feel better. But narcotics suppress your own dopamine. And that's why you constantly eat more highs. Your own dopamine system doesn't work. And you get what's called rebound. Migraine patients especially get rebound a great deal if you take too much medication. You take more than 2 pills a week, for example, for migraine headaches, you will get rebound. The blood level drops, and then you will crave for more medication. If you're taking medication every day, for example, for migraine headaches, you will get a rebound, and you will never get over it. I mean, if you have cancer and you were to become addicted, I wouldn't be concerned about it. There isn't enough. I wouldn't be concerned about it. But the rest of us, if you have no cancerous condition, we really have to watch for that. And so, what's pain, really? It's a fraud. Chronic pain, I'm talking about chronic pain, not acute. Acute tells you where the problem is, you fix it, and it's gone. But chronic pain, long-term pain, 70% of the time is a fraud. It's just a fraud. Well, why is it a fraud? Number one is it doesn't identify anything. You get pain, but there really isn't anything clearly wrong in any part of the body. And also, it's a fraud because the provider can use diagnostic tests, CTs, MRIs. Radiologist overreads them because it's such a normal process of aging, and you're convinced there's something wrong. That's the nocebo, negative speak. Placebo is, if you believe this pill I give you, you believe it, it'll work 70% of the time, even if it's inert, even if it's a sugar pill, okay? But a nocebo is the negative speak of your x-rays. You get an MRI and it's overread, like this gentleman I saw today, at 308 pounds, normal x-rays, they've been overreading it because one of the pain centers owns the MRI machine, okay? And their radiologists overread the films, and it gives them an excuse to do something. And I know the patient was disappointed when I said his x-rays were perfectly normal. That's the nocebo, the negative talk. So the provider can be part of the fraud. Not every provider, but some providers, okay? And pain centers, not every pain center, but a lot of pain centers are real good at this all over the country. I know, I visit them. I look at the people sitting in the pain center. It's like you're in an opium den. Just walk through a well-known pain center and you see, look at the people. You want to be part of that crowd? I mean, they look addicted. They look addicted. And obviously, they become addicted. And a lot of them initially started the addiction by the provider with the prescription. The legal addict. They are the legal addicts sitting there, okay? But they look like all other addicts. And disability is used a lot in pain syndromes. I mean, if you're trying to get Social Security disability, VA benefits, pain is used a lot. A lot of that's perfectly honest, but there's no doubt in my 42 years of doing this, I see plenty of people exaggerating the pain syndromes to get a disability check. Do I totally blame them? No. We have terrible economic times, and I can almost understand it, but we should be aware of it. We should be aware of it. and accidents. A lot of lawsuits, rear end collisions, things. You see all these huge lawsuits over nothing. And so who's involved with the fraud of pain? A lot of people. I wrote a book on it. You might enjoy reading it. It's on Amazon. And a fraud of chronic pain. And it really looks brutally at the pain problem. And it also has in it, half of the book is holistic methods of treating them, from relaxation to breathing techniques to music to dancing to massaging to yoga to all sorts of method of treating chronic pain without narcotics. This morning at Starbucks, I met someone who did some counseling for patients with narcotic problems and stress and things, and her license is in counseling. She's not a psychiatrist, a psychologist. And I said, can you write a prescription? No. She says, I cannot legally write a prescription, although I have a backup person, a psychiatrist, but I don't write. I said, how do you get people well? She says, I get people well with holistic methods. So we develop a friendship. We're going to open a holistic pain clinic in this city because I've finally found somebody that could help me do that, because I'm a bit of a busy guy, as you can imagine. And she is getting people well by talking to them without any medications. Would you believe it? Would you believe it? I mean, I think God took care of me today. And to meet this nice lady. And I'm going to do one of these shows with her, I think, in the future. So there's the central and peripheral theory of pain. I mean, you go to a pain clinic today, and this really is a scandal that since 70% of the pain is metabolic pain, it's due to anxiety, it's due to fear, it's due to stress, to hopelessness. It's the bumps of your life. So where's the pain located? Obviously in your brain. That's a central theory of pain. But the brain is very sharp. The brain is very sharp. It can't get narcotics for brain pain. So what does the body say? My back hurts. My back hurts. And that suppresses your own dopamine system. This is something very hard for a patient to understand, but it's the truth of the matter. It's the truth of the matter. So, of course, when you go to these lectures at pain meetings, pain societies, American Pain Society, I mean, they will totally debate this theory. They'll say it's most pain is located peripherally in the spinal cord. It has nothing to do with the head. Well, I tell you, they just happen to be dead wrong, and most of us know that. But if you're trying to make your money, here, I mean, what do you think? What side are you going to argue on? You know, my patients call pain centers, and they mean it too, cash cows that addict people. That's what they call them. I had that patient tell me that in the office. The one I went to the 3 pains, he called them cash cows that addict people. They know that, and they're willing to put up with the injection. The pain doctors know this. It's the key that unlocks the door to the narcotic. The injection is the key to unlock the door to the narcotic. Yes, that's how it's done, and the patients know it, and they're willing to put up with it. And unfortunately. And so what is pain? A perception, an emotion, a sensation. You know, interestingly enough, it's different among different sexes. The females appreciate pain more. If you put a female's elbow inside, say, ice water, she'll withdraw it 30 seconds faster than a man would. That's nothing derogatory. It's just the genetics of it. That's just the genetics of it. It's different in different races. Yes, there are differences in races. There are differences in cultures. And societies. The same race in one country may be totally different in another. If you were to go to Kenya, for example, or Egypt, or these countries, they give morphine in the hospital for cancer. That's it. It's not used on the outside. And they don't seem to have a lot of pain. A friend of mine visited a hospital in Kenya recently because his daughter's working there, and went to the delivery room, and there were women who just had a baby, going to have a baby, one's in labor. He said it was the quietest room in the hospital. No one was complaining of pain. Kind of interesting. My friend Dr. Ireland, who unfortunately left town, a chiropractor, his wife, Oksana, had a baby at Lutheran Hospital maybe 9 months ago, and I happened to be walking through the hospital. I saw him, and I said, Oksana just had a baby. So I went up, and I said, Oksana, I said, she's a from Russia originally. I said, what did you use for anesthetic, epidural? He says, Dr. Cashman, he says, I attend your lectures. He says, I attend your lectures. I just meditated, did some deep breathing. I didn't have any pain whatsoever. Now, I'm not saying this is what you ought to do, but indeed, she did it. And a lot of people do that. So perception of people in other cultures a lot of times is that they don't have pain at all. So, and I tell you what's a problem coming up here, now that the government is going to pay the hospital more for patient satisfaction, okay? That doctor is getting training for that. I was just in an alumni meeting down at IU, and one of my dear friends, Dr. Kirshner from Marion, has had to take a course in Peru Hospital on patient satisfaction. They're bringing in, because every hospital wants that extra percentage from the government for patient satisfaction. Now you tell me, if you want great patient satisfaction, one way to do it, you just hand out Dilaudid morphine all day and they're going to have great patient satisfaction. Now an honest doctor goes in and says, I don't know why you hurt, I think you ought to try some other medication or try some holistic methods. I'm not going to give you this narcotic medication. And they're going to write a very unsatisfactory report. And this is how the government is going to pay the providers in the hospital. It's perverse. It's totally perverse. The government has helped promote this. And I tell you, in other ways, the government helps promote pain, because 90% of the people that attend pain clinics today, and I know this for a fact because I've spoken to people that work there. This psychologist I met with today, who treats counsels psychiatric patients, says 90% of our patients are on Medicaid. 90% of the patients in most pain clinics are on Medicaid. And you know what goes on over there? And I'm sure Medicare may not act like they're totally aware of it. I'm sure they don't do this on purpose. I'm sure they're trying to help people. But let me tell you what you're actually doing. You're paying for the taxi driver to pick up the patient at home who may be addicted to drugs. You take them to the pain center, you drop them off, and the driver waits there. Then they pay for the injection, they pay for the doctor, they pay for the medication, and they pay for the taxi ride home, and none of that has a deductible. Medicaid has zero deductible. For people who are really ill and really poor, it's a great thing. But the amount of abuse is beyond comprehension. I know, because the doctors that deal with that tell me that. And just think, so what is Medicaid doing? They're promoting addiction. I hope they're watching the show. I'm just saying the way it is. And I'm certain that's not in their heart. That is not in their heart. It's based on the legislature, perhaps. I'm certain that's not in their heart, and I don't personally blame them, but that is the situation, and Medicaid must wake up to this. They got to stop transporting these addicts to pick up their medication, pay for the medication, pay for the taxi ride, pay for the doctor, pay for the unnecessary procedure. We're talking about billions, billions. Remember that letter of the New York Times? $600 billion this year, based on cigarettes, alcohol, and narcotics. This is what they're paying for, and we poor taxpayers are paying the bill. And I'm not even complaining about the bill. I'm complaining about the people that are addicted. When people become addicted, let me tell you something about addiction. Become addicted, they have no control of themselves. Don't just blame the addict. They want to throw him in jail, like I saw him take the actor Douglas' son, they threw him in jail. What good does that do? They need treatment. An addict has no control. When you're addicted, your focus narrows and narrows and narrows, that your brothers, your sisters, your mothers, your family mean nothing. Means nothing. So to take a normal person and addict them, like I see constantly in almost any provider's office, but extremely high number in pain centers, is sinful. It's nothing but sinful. That's why I'm trying to change it. We need a new definition of pain. It has to be redefined. People with metabolic pain should not receive narcotic prescriptions because they can be addicted. I know of some pain centers that went to, I had a patient write me up 30 pages to go into 5 different pain centers in the city. Everybody injected her spine, everybody did epidural blocks, everybody did rhizotomies, and then they said to her, do you want methadone, OxyContin, or morphine? She wrote it up, 30 pages worth, in her own handwriting, and it's going to be in my book on my pain book, we need a definition. In our own handwriting, that will be in there. I'll probably be merciful when not name the senators themselves, but it wouldn't be hard to guess who they are, since there aren't that many of them. Opiates were used for 2,000 years, okay? Then morphine was derived in the 1800s. A derivative called thebain, Thebain, that's hydrocodone. That's only grown in 2 or 3 countries in the world. The international UN keeps fairly reasonable track of it as best that you can. You only can carry it so far. So what are we really talking about? We're talking about iatrogenic, physician-induced addiction. There's more of that in this country than the street guys. More doctors, providers are addicting patients than the street guys to narcotics. The message has to come out. It's been in the newspaper. This is nothing unusual that I'm bringing out, but it must be faced. It must be faced. We cannot just let this continue. Because remember what I said? You addict someone, odds of them getting rid of their addiction, maybe 10%. If you could throw them on a farm for 6 months and getting marching around and give them therapy every day, like this patient with the 30 pages I talked about, went to a place called the Orchid in Florida. Her mother could afford it, spent $15,000, and eventually she got off it. But that's not going to be the majority of the patients. That is not going to be the majority of the patients. So to addict people, we have to stop doing this. But I tell you as a patient, don't accept a narcotic unless you have acute pain or you get cancer or some other neuropathic pain problem where clearly there's been some damage to your body. You may need to take a narcotic. That's fine. That's fine. And but don't just accept it for a metabolic benign pain problem or where you don't even know what the cause is. And with the Joint Commission wants all the pain to be controlled, okay? You have an 8, you got to give a narcotic. Don't even care what you got. The problem is you may have a patient with no pain. The patient I saw today, for example, as long as he's on his OxyContin, he has very little pain. Is he working? No, he's not working. What you do is eliminate that person's functionality. That's a big point. You may have no pain from all the narcs they're giving you, but you're not functional. You're not functional. You're not going to be working. Occasionally they take a patient, they put a pain stimulator or something, and I saw a young man the other day, and he was working in the pumping narcotics into him every day into the spine. But what do you think is going to happen over the next few years? I mean, you're going to have to constantly increase the narcotics. He's an addict. He's an addict. Say anything that you want. He's an addict. And you're going to have to increase and eventually you need a fentanyl patch and whatever. What's a benign condition? He had no cancer. He had a pain stimulator. The whole thing is ridiculousness. He could be gotten well with holistic methods of exercise, from Tai Chi to Qigong to music to dancing to laughter to funny movies like Norman Cousins speaks about in his book. So the loss of function is critical. We are causing loss of function with these narcotics. We're having a society with no pain, but nobody's functioning. Have you noticed Social Security disability doubled in the last 5 years? Doubled it. The economy has something to do with it, but so does all this addiction across the country had a lot to do with it. Who's paying for all this? Insurance companies are paying for it. I went over to PHP and asked them to maybe send me their pain patients before they send to the pain clinic for a second opinion. They never did it. They even called back. They're not interested. I called and I've alerted Medicaid. They ought to pay some attention to what they're paying for, and it's difficult. I'm sure in the hearts are pure, but that's not the point. But if they're paying 90% of the bill at a pain center, that's a major mistake. I asked Medicaid to wake up, and if they stop paying for these things, then guess what would happen to this unnecessary treatment? It would shrink up in a minute. They're not doing this to entertain themselves. They're doing it for the money, obviously. Else would you be willing to addict somebody unless it was for the money? And I mean, any patient would tell you that. That's nothing, I'm saying nothing unusual here. And Forbes magazine published an article in 1995 called The Morphine Myth. They were dead wrong. They followed Portnoy's lead, and they were just dead wrong. April the 9th of this year, New York Times, look it up yourself. Barry Meyer, a New York Times reporter who published quite a few things about oxycodone and Oxycontin over the years. So he was kind of an expert. He himself wrote a book called Painkiller. I like to hold it up. I think it's a good book, Barry Meyer. Brutal book, brutal. When it came in the mail to me and I started reading it, knowing what I know about pain, you know what I did in spite of working all day, in spite of surgeries the next day? I spent up the whole night reading it. It was that interesting. He's the one that traced the Sackley family from New York, the Purdue Company, and their advertising methods and their promotion of these medications. I think all three Sackley brothers are dead now, but if they're looking, I suspect they're looking up at us and not down on us. They created a lot of havoc, I'm sure a few cancer patients are grateful for the medication, no doubt about that. But the amount of addiction and deaths from these addiction is mounting up very rapidly. I mean, I've visited the coroners of different counties, and they're so concerned, like I called the Huntington County Coroner's Office and the narcotic detective. I called them at 9 in the morning on Monday. They met with me at noon. That's how concerned these people are, because they had 2 deaths from complications of narcotics from pain centers. From pain centers. That's where the prescriptions were from. They showed me the pills. And 90% of these patients are Medicaid. 90%. So I say, wake up. Wake up, wake up. And so Forbes was dead wrong in saying that morphine is not an addictive drug. And the American Pain Society should be called the American Pharmaceutical Society. But to take them on, for me to take them on, is impossible. Too much money involved. It's a road to nowhere. So I'm exposing myself to the public, and the public gets it. The patients know. They come to see me. They know quite a bit. So in about 1995, Purdue Company started working on OxyContin. It was used for cancer, but by 1997, the FDA approved it for non-malignant pain. They approved it for non-malignant pain, and without good studies. They never really exposed the public to it. They never checked to see what the street people could do with it. They studied it in Canada. And they quickly found out that the Canadian authorities went to the street people. They went to the street people. They quickly found out how OxyContin could be abused. You chew it. It gives you a quick, immediate high, and the street people just loved it. Remember, addiction is overwhelming high, craving, and willing to do something illegal to get it. That's the definition of addiction. The World Medical Society, though, decided to even drop the word addiction. They just called it habituation. They just called it all habituation. So that there's a line that you could, argue about. Dilaudid was brought to the markets in 1930 as hydromorphone. Hydromorphone is used very commonly today. It's very addictive. It's very addictive. So a patient just go to the emergency room, like one of my post-op patients, instead of coming to Lutherans, went to an outlying hospital, and the emergency room doctor right away gave her Dilaudid because she said her back hurt. And I realized I might have been a little bit pushy here, but I called the doctor up and chewed him out. I did. I don't want my patients to be given Dilaudid unless they get cancer, a broken leg, or Kirkland ruptured disc. A little backache after surgery is just not going to do it. And that's me. Not everybody would agree with that. But if someone doesn't draw the line and stop, we're going to addict the whole country. And it's ruining so many lives, lives. So I think we need to redefine pain. The Joint Commission of Hospitals need to get to the table. They published another paper, I think, just a few years ago, when they said they thought the definition was wrong. It was too liberal. It was too liberal. I think these pain centers, what to do? I don't think the medical society is going to do it. what to do about it. I think someone needs to go in there and have a look at these pain centers and see what they're doing. Unfortunately, that's going to catch up in a few good centers in town, no doubt about it. And I compliment them, but unfortunately, they are going to get caught up in whatever needs to be done, because they themselves are not reforming themselves. That would be the best if they would all form an association, but the trouble is that I'd say at least half of these centers are a problem. So how are they going to police themselves? I think it's extremely difficult. So what are holistic ways of getting well with a pain problem, for example? Number one is, I think you have to educate the patient. I spent a lot of time educating people. I have CDs, DVDs, audiobooks, books, and it's difficult when these patients are addicted to get them to read, for example, or to get them to listen to something. It is not easy. I have to really muscle it and spend the time, probably 30 minutes a day. I threw my office way out of whack because this gentleman that weighed 380 had this problem. I think he was sincere in trying to get well. I had to make him understand that the x-rays were normal. It never could I get him to believe it, but finally I think, but I have pain. I said, you realize you have pain, but it's centralized pain. It is real pain. But finally, I think he did understand. It took me an hour, but you have to be willing to muscle it. You can't just write a prescription, go to a pain center. That's where the mistake a lot of time is. I see a family doctor, and they'll have a complaint they can't deal with, and say, go to the pain center. Major error. Major error. I've seen this mistake again and again. And then the first thing happens, of course, injections don't work, and then the narcotics start, and the addictive process starts. I wrote a book originally. I have a series of books on this matter called Nocebo, the Evil Twin. Very easy to read, 50 pages. And what I'm saying is here, remember I spoke a little earlier about the placebo. You believe. It can be a provider, it can be a pill, but the nocebo is overreading of the MRI, the angiogram, to convince somebody they need something done, when in reality maybe they don't. So you got to admit, this is a pretty clever title here. Nocebo, the Evil Twin. I mean, it's an evil twin, isn't it really? I probably have spoke to 300 providers, God knows how many nurses. No one ever knew what the word nocebo meant. It's in the dictionary. I didn't know it. I found a book somewhere, and very little has been written about it. Placebo, there's probably been a million articles. Nocebo, I may be the only book on it, and a term very rarely used. But how we speak to patients in our practice of medicine, you see, is very important. Is all this negative speak. We can convince people that there's something wrong when maybe we get a little more history. You know, I hand people a lot of times a yellow pad and a pencil. Write me out what's going on. What's going on in your life? That's the opening words, unless they fell out of an airplane or something. A lot of times I'll say, what's going on in your life? And there is the diagnosis, because you get the declaration of their symptoms. Very important. And then I follow that with another book, The Fraud of Chronic Pain, also on Amazon or a different bookstore, where I really, I edited that pretty brutally. But half the book is about teaching you how to get well without medication, injections, or surgeries. It's a good 200-odd pages. And now I'm following it up with pain, a new definition. And I think that's the only way to get this thing cured. We have to learn to understand that this thing from the Joint Commission, what's the level of your pain, 0 to 10, is not going to do it. That's just not going to do it. That leads to so much over-treatment, costing everybody, a lot of money, and we could save, I think, billions in this nation if this was done. It would also reduce, I think, the amount of surgery that we do, because some of the surgery is also based on overread x-rays, and that can lead into chronic pain problems. And also, if you're particularly interested in this, I encourage you to read Painkiller by Barry Meyer. I think This is the history of pain clinics. Once you understand the history, and it's pretty short, you know, about 1986, that's when the pain clinic started, and 25, 28 years later, I think we're maybe starting to wake up that something else, needs to be done. As a patient, I recommend that you maybe get a second opinion. I'm writing a book actually on Doctor's Second Opinion. It'll be out in a couple of months. But some things are worth getting a second opinion about. I mean, if they want to operate on you as an emergency, maybe you ought to get a second opinion. If they want to hand you a narcotic medication, I think if you watch this program, I think you will realize that narcotics will change the neurochemistry of your brain. It will change the neurochemistry of your brain, and you have to be very careful. Short-term use, month or so. If you have something going on, no problem. You get a broken leg, for Pete's sake, take it. You take cancer, take it without hesitancy. Give it to your IV, pain pump, whatever. Don't hesitate. And there's some neuropathic pain syndromes, take the medication. But don't just accept it for some light arthritis or, oh, my back hurts, or fibromyalgia, especially fibromyalgia, that type of pain. Don't accept a narcotic. You could end up with a second disease called chronic pain. It could be called chronic pain. Now you get another problem. And you may need narcotics all your life. You'll be looking for injections all the time. A lot of the, you may feel better from an injection 2 or 3 days. That's a placebo effect many times. And sometimes it truly does help. I'm not totally against them, but I'd be careful, about them. In summary, thanks so much for listening to me tonight. I'm obviously passionate about it. I see it every day. If I see a patient turned into an addict, I see nothing but pain and a poor life in the future. I'm trying to help the people. Please give me a hand. You get a good pain story on medication, send it to me in the mail. I might throw it in my books. Because I'm working on this every day. Every day I'm working on this problem, trying to help people. You got to remember, I'm Dr. Wellness. I'm Doctor's Second Opinion. I have your health in mind, and I appreciate very much your listening to me tonight. It's a two-way street. I'm welcome to your comments and provide for me some new information. Send me a book, whatever. I learn something every day. I learn something every day. I'm a voracious reader. Thanks very much for listening to me. And I love you all. Thank you very much.